Hey there everyone, this is Adam again, and today we're covering our third unit for pharmacodynamics. This is going to be covering a lot of the basics on pharmacokinetics, specifically including absorption, distribution, metabolism, and elimination. So, as we had said previously, pharmacokinetics is really going to be primarily the effect that the body has on the drug. So this isn't really so much on how the drugs interact with the receptors to cause their physiologic effect, but this is what the body's doing to it to not only get the drug into the system, but also to get it out of the system and where it goes within the body. So we'll talk about the four components of pharmacokinetics, the A, D, M, and E, standing for absorption, distribution, metabolism, and elimination. We'll cover also some dosing issues, including things like loading doses, why we might use a loading dose, how that relates to steady state, and then we'll talk a little bit about drug toxicity, and namely how the kinetics of a drug and how the body is processing it can lead to super therapeutic levels leading to toxicity. So I went ahead and skip past the objective slides since we'll be covering those in more detail as we go forward. But this picture here basically gives a good overview of kind of the interrelationship between the different components of pharmacokinetics. So here I'll get a laser pointed out. So initially what we're going to be seeing is that when a dose is initially ingested or however it's being administered, we'll do oral as the most common example. Once the drug is given, from that point, once it gets into the GI tract, we're going to see a period of liberation where the drug is actually dissolved and is liberated from its dosage form. And then at which point the absorption component comes into effect. Obviously, different routes of administration will have different absorption rates. So you see that obviously things like IV is going to have 100% absorption, where other routes may have less absorption, especially depending on the drug and depending on the situation. So once that absorption occurs, then now you have free drug sitting here in the central compartment. So you can kind of think of this being here within the blood, within the serum, kind of free drug is just floating around. Now we'll see that some portion of the drug, depending on the physiochemical properties of it, may be bound to proteins within the blood. So this can include things like albumin, alpha-1 acid-glycoprotein, things like that. But more importantly, what's going to be happening to this free drug, especially if the site of action is not in the blood itself, we want it to get to its tissue where it's going to be effective. So we'll see that the distribution phase is going to be really important here, where this free drug is going to be moving from the central compartment out to the tissues to where it can interact with the receptors and have its clinical activity. You also see that you'll have a certain amount of drug being within the tissues, where it can either be kind of in a free or the bound form. So obviously drugs that are bound out to the tissue, they are not able to kind of freely distribute between the central compartment from the central compartment to the tissue so well, but this is where we can see certain drugs can actually have buildup in the tissue bound proportion. So say for instance, if you're ever having a urine drug screen for something like THC, especially those that are chronic smokers, that are heavy smokers, they typically have a lot of tissue reservoir bound up to where they can test positive for several months after their last time smoking, just based on the fact that some of that THC will bind out to the tissue. We'll also see some of the drug is going to go to unwanted sites of action, so we'll talk more about that when we get to the toxicity. And then in conjunction while all of this is happening, this distribution, we'll also have a proportion of the drug that's undergoing biotransformation. And so this is going to be the main site where metabolism is happening. You'll see that the majority of this happens within the liver, but certainly some could happen in places like the blood. The metabolites themselves, they can either be excreted in a variety of organs, so they can be excreted through the kidneys, some will go through the lungs, some will go through the biliary tract, and so this is kind of the clearance aspect of it when the drug is actually being eliminated. So all of these components kind of interplay with one another to get the full pharmacokinetic profile for a particular drug. And so from here on, we'll talk more about some of the details of that as we move forward. So the first thing we'll hit on is going to be absorption and distribution. And so this is the way we're actually going to get the drug into the body itself. And so a lot of this is going to come down to permeation of the drug as it moves through various biological membranes and through different barriers. So these barriers can be anything ranging from the intestinal wall, the capillary walls, the blood-brain barrier, especially for drugs that have their site of action within the CNS. It's going to kind of rely on diffusion of the drug first, and then aqueous diffusion. which we know is a passive process. It's going to be driven mainly by concentration gradients. And so anytime you're having passive diffusion, you'll be seeing that it's, because it doesn't require energy, you're going to be seeing that these are always going to be processes where things are going from areas of high concentration to things of or to areas of low concentration. Once a drug or a molecule has kind of undergone this aqueous diffusion, in order to cross these biological barriers, it's going to have to undergo this lipid diffusion, where the drugs are able to cross these lipid membranes to, say, go from the GI tract into across the intestinal wall, or from the bloodstream across the blood-brain barrier to get to the CNS. And we'll see that one of the big factors that is going to be influencing this are going to be whether or not the drugs themselves are weak acids or weak bases. And then depending on that, their pKa and also the pH of the solution that they're in, because this can change the charge on the molecule. And we'll know that things that have charges on them are going to have a harder time crossing that blood-brain barrier rather than something that has no charge on it, which is going to be able to be more lipophilic and thus cross more easily. So we'll get more into detail on this in just a minute. We talk more about things like the Henderson-Hasselbalch equation. We can also have more active forms of absorption of these medications. So certainly there's ways of carrier-mediated diffusion. These are going to be better for things that can't pass by diffusion themselves. So whether or not the molecules are too big, or there's too much of a charge associated with them, or whatever the reason is, if they're not able to cross this membrane on its own, you'll see these carrier-mediated active transport processes occurring. And in which case, because it's an active process, it's able to go against its concentration gradient. So in some cases, you may have things going from areas of low concentration and being concentrated into an area of higher concentration. No, like we said with this aqueous diffusion, it's going to be occurring across these larger aqueous compartments of the body. And so certainly we can see transport of drug through aqueous pores in the endothelial lining, especially in the blood vessels. So this is a way we get good transport of molecules between the blood and extravascular space. And one of the big things you're going to be seeing here, and what governs this, is going to be the concept of Fick's law. So Fick's law is a way we can look at several components of not only the drug itself and the concentrations, but also looking at the membrane that it's trying to cross to see how well that's going to occur. And so again, this is going to be the passive process, so it's going to be relying on concentration gradients in order for this to occur. So the different components here you're going to be seeing are C1 and C2. C1 being the higher concentration that you have, and C2 being the lower concentration. We're looking at the area, so obviously the larger the area that we're going to have available to us, the more likely we are to have a better absorption or better flux. As you can see here, so this is where we look at places like the GI tract, where you see lots of surface area based on just the anatomy of it, all the kind of the ridges and folds and things like that within the GI tract that help to increase the surface area. Another important component here is the permeability coefficient. So this is the ability for the drug molecule to see how mobile they can be within when they're crossing this membrane. And then thickness is going to be important as well, because we'll see an inverse relationship here, where the thicker the membrane we're dealing with, the more difficult it'll be for those molecules to cross, and thus you'll have lower amounts of flux. So again, looking at the different components, obviously things with large concentration gradients, you're going to have faster diffusion and better absorption. So again, increasing your dose or increasing concentration is going to help versus having a lower concentration. Also see that organs with large surface area, especially things like the large intestine, versus things with small surface area like the stomach, are going to have more flux and thus better absorption of these drug molecules. We'll also see that areas that have thin membranes are going to have a lot easier time. I'll show you a picture of that in just a second. So obviously things like the lungs are going to have very thin membranes, very well vascularized. They're going to have an easy time crossing drugs over. So you can get some drugs that will actually have good systemic absorption after being inhaled, versus areas that have more thick membranes. So things like the skin are going to have a harder time having absorption. That doesn't preclude absorption from occurring, because we know that we can have transdermal application of certain medications, but it has to be overcome in some other components, either with surface area or looking at something like the concentration gradient. Increasing that can help overcome that thickness that comes along with the skin. And then again, the body is by limiting the amount that can be absorbed here, the body's helping to establish the steady state of the drug. And so we'll talk about steady state a little bit later, but essentially what this is doing is establishing how much is coming into the body versus how much is being excreted. And at a certain point, you're going to be having those numbers kind of match to where you've reached the steady state. And there'll be a certain concentration of the drug that goes along with that. But there'll be more of that we'll talk about in just a few minutes. So looking at this picture kind of gives a good illustration of Fick's law. So again, looking at the various components, obviously the larger the concentration gradient we have between the outside to the inside area, the higher the amount of flux we're going to have, because it's going to, just by having that higher gradient, you're going to have more molecules to push across that membrane. Obviously, the larger the surface area, the better flux we're going to have, and then the smaller or the thinner the membrane, the better absorption you're going to have. A lot of this still applies to lipid diffusion as well. It's just you're dealing with lipid barriers versus just, say, dealing with aqueous pores and things like that. Now, the bigger component that's going to be coming into here is going to be having to do with pH and ionization of the drug itself. So looking at lipid barriers, obviously they can provide a very significant barrier to absorption. And so looking at the pH of the medium that the drug is in will determine its ionization state. And so things that are charged tend to be more lipid insoluble and more water soluble, so they have a harder time crossing those lipid membranes versus things that are uncharged. They're going to be more lipophilic, they're going to be more lipid soluble, and this will have an easier time crossing. And so the things that are going to be determining this are going to be the pH of the solution and the pKa of the actual drug itself. And so we can see that when using weak acids and weak bases, which a lot of drugs can fall into either category, this relationship can be described with the Henderson-Hasselbalch equation. So just to look at the definitions on how we'll be annotating this in the upcoming slides. So the pKa is going to be the acid dissociation constant. There's also pKb's, but we'll stick with pKa just for our purposes here. When you see HA, that's going to be a protonated weak acid, which is going to be in the uncharged state. If you say A minus, it's going to be the unprotonated acid, thus it's going to be in a charged state. And then conversely, you'll see that BH is going to be the protonated base, but it's going to have a charge associated with it. And then B is just going to be the unprotonated base. It will be uncharged. So you're going to see there's kind of an opposite relationship between the acids and the bases here in regards to their absorption. So looking at this picture here, we'll basically take it one at a time, but looking at the weak acid portion here on the left, essentially what you have is you're going to have your body compartment. Say this is going to be the GI tract, and here's the intestinal membrane, and then here's the blood supply, basically. Here's your lipid membrane that the drugs have to cross in order to be absorbed. Looking at weak acids, what we're going to be seeing is that when the acids are in a state of having an extra proton, having an extra hydrogen ion there, they're going to be in an uncharged state. Thus, they're going to have an easier time crossing this lipid membrane, versus the unprotonated acid is going to be in a charged state and is going to just basically bounce off this lipid membrane. And of course, every drug is going to kind of be in an equilibrium where there's going to be a certain proportion that's going to be charged versus uncharged. And so it's not to say that this molecule couldn't later have a proton added on and then be uncharged and then cross. It's just at that current state, it's going to bounce right off. And then based on the pH of the kind of the receiving body compartment, you may have states where the pH is different enough to where you can actually end up trapping some of these molecules in here. So we'll see that becomes important when we talk about things like transfer of drug molecules into breast milk, where you can actually have concentration of the drug because certain molecules can be trapped within the breast milk because it's a different pH than maybe what the blood was. Now on the opposite side, looking at the weak bases, what you'll see here is the complete opposite, where you have bases that are going to be in a protonated state, where they have that extra hydrogen ion. They're going to be in a charged state, and thus are going to bounce off that lipid membrane. So anything charged is not going to have an easy time getting absorbed unless there were, say, a specific protein transporter, in which case we wouldn't be dealing with really passive diffusion. It's more going to be active diffusion. But if the base is in an unprotonated state, it's going to be uncharged. It's going to have an easy time crossing that lipid membrane. And again, the same thing can happen here where depending on the pH of the receiving compartment, you may see a higher proportion of that base reaching more of the protonated state, and thus it's not going to be able to cross back over to the other side of the lipid membrane. And so looking at the Henderson-Hasselbalch equation, I apologize for the picture being a little blurry, but you basically get the idea here where when looking at a given pH of a solution, the pKa of the drug plus the log of the non-protonated species to the protonated species, and this is really just going to be this ratio of one to the other, will be able to give you this relationship and tell you how well a drug is really able to be absorbed. And I'll show you in a better picture in just a second how that looks. But essentially for acids, what we're looking at here is that at a given pH, with the pKa of the acid, we're looking at the log of the non-protonated species over the protonated species. So the higher that we can drive this proportion of drug into the protonated state, the easier time it's going to have being absorbed across the lipid membrane. And the exact opposite holds true for bases, to where if we want to drive, if you want to have better absorption, you want to drive the base to be more in this unprotonated state, non-protonated state where it does not have a charge, and that's going to have an easier absorption. So we'll see, and it's a good thing to remember the old adage that like dissolves like, because we'll see that weak acids are going to have an easier time being absorbed in acidic solutions, whereas weak bases are going to have an easier time being absorbed in more basic solutions. So I like this picture a lot because I think it makes it a little bit easier to understand what the Henderson-Hasselbalch equation is trying to get at. But essentially, when you're looking at a specific drug within a solution, when the pH is equal to the pKa of the drug, you're going to be seeing that there's a 50-50 split between the protonated and the non-protonated species of that molecule. So if the pH, the pKa of a specific molecule is 6.5, and the pH of the solution the drug is in is 6.5, then you're going to have a 50-50 split between the protonated and the non-protonated species. Now, if I start to drop the pH below the pKa of the molecule, you're going to be seeing there's more hydrogen ions floating around. You're going to have a higher proportion of the drugs being in a protonated state, which means that when you put this into a more acidic solution, you're going to have a higher proportion of the acids being in this protonated state, meaning they're going to have an easier time being absorbed, whereas the bases are going to be in a protonated state where they're going to have a charge and thus have a harder time being absorbed, right? So if you put a weak base into a more acidic solution, you're going to have a harder time for that drug to cross a lipid membrane. The opposite holds true, where if you increase the pH that a drug is in above its pKa, you're going to have a higher proportion of the drug being in a non-protonated state, meaning for acids, it's going to have a harder time being absorbed because it has a charge on it, versus bases will have an easier time being absorbed because they don't have a charge. And I can show you some examples of this, how this is important for not only drug absorption, but also can be really important for drug elimination as well. We talk about renal clearance. So, like we said, in an acidic solution, weak acids tend to be more in their protonated state, thus they're going to be uncharged and more lipid soluble. So say, for instance, you're looking at something like aspirin. Aspirin is a weak acid, and when you put it into a more acidic solution, it becomes more protonated, and thus you're in that HA state, and thus you're going to have better lipid absorption because it's more lipid soluble. Whereas on the other hand, weak bases are going to be in an acidic solution more protonated, thus they're going to have more of a charge, and they're going to be more lipid insoluble. So the protonated form, say of something like morphine, which is a weak base, makes it less lipid soluble. Thus it's going to have a harder time crossing that blood-brain, or crossing that lipid membrane. So here are just some examples to show you different drugs that fall into categories of either being weak acids or weak bases. Again, no point memorizing pKs of specific drugs because clinically it really doesn't come up all that often, but this at least gives you the background on why certain drugs may be absorbed from different parts of, say, the GI tract. So say something like a weak acid might have an easier time being absorbed from the stomach, which is a lower pH than, say, in the duodenum, where you're going to have higher pH that's going to be have a harder time being absorbed. So you can kind of gives you some background on that. Again, look at things like acetaminophen, aspirin fall in this more of a weak acid category. Even the pKa's can range pretty greatly between them versus some of the weak bases, so things like cocaine or ephedrine, chlordiazepoxide, which is a benzodiazepine, so it's very similar to something like alprazolam or Xanax as a brand name for that, and then morphine falls in this category as well. So not everything goes by passive diffusion. As we mentioned, there are also things like special carriers. So they can exist for certain substances that are important just for cell function. So you can have things like amino acid carriers in the blood-brain barrier. There are certain weak acid carriers that are reside within the renal tubules that are important for absorption or excretion of different substances within the kidneys. And so this is going to be useful for medications or other molecules that either are too large to passively go through the membrane or have some other physiochemical property that makes them incompatible with this passive diffusion. And one of the big things here is that these are, since they're active processes, they're not going to be governed by fixed law and thus are going to be capacity limited. So something like fixed law, if I keep increasing the concentration gradient between my C1 and my C2, I'm going to keep increasing the amount of flux. There's no real ceiling on that for all intents and purposes. Whereas on the other hand, if I have certain transporters that are responsible for moving these drugs over, once I kind of bind up all those transporters and they're all busy doing their drugs, just because I keep increasing the concentration gradient doesn't make it go any faster. You're really going to be limited by how many of those transporters you have. So again, they can become saturated. And so because this is an active process, it may also go against the concentration gradient. So it can go from an area of low concentration to one of high concentration. So a good example of this would be the multi-drug resistance type 1 or the MDR1 transporter. Another good name for this is going to be P-glycoprotein or PGP as it is commonly abbreviated. And so this is found in many areas of the body, including the brain, the testes, and also the GI tract. And so this one's actually going to be really important for drug efflux, meaning it's going to be actually forcing, in a lot of cases, forcing drugs out of an area. So it's kind of a protective type transporter where trying to get rid of certain molecules in order to help protect the cell in some cases. So this is why it's important for things like the brain where you don't necessarily want a lot of molecules getting into the CNS that it shouldn't be there. So this MDR1 transporter can basically kind of pump things out of the CNS and try to protect the brain. And so you can actually see that certain drug interactions can come about by manipulating this transporter. And so you can see that certain things may actually inhibit or induce this transporter and can lead to some very significant drug interactions. So say, for instance, if you ever heard of, don't take grapefruit juice with this drug, this is one of the interactions that we're talking about. So statins is kind of a term we use to classify some of our hyperlipidemia drugs, the HMG-CoA reductase inhibitors. So this would include things like atorvastatin, rosuvastatin, simvastatin, and so these drugs are really important for treating hyperlipidemia, and they're also effluxed out by this transporters, specifically in the GI tract. So this is one of those situations where if I inhibit this transporter by something like grapefruit juice, which has certain proteins in it which inhibit this PGP protein, what actually happens is that the transporter can't efflux the statins out through the GI tract unless you end up having buildup of the drugs within the blood, which can lead to some very significant organ toxicity like hepatotoxicity, and can even lead to things like rhabdomyolysis. You have significant muscle breakdown due to too high levels of these medications. So again, just another couple of pictures to kind of show you an example of where these MDR proteins become important. So specifically when you're having certain molecules being excreted out to the GI tract. So here we have hepatocytes that are exporting molecules out through the bile. Here we have a couple of different MDR proteins here that are responsible for that. Again, certain transporters will be good for different types of products. So for things like the oat proteins, like these are going to be organic anion transport proteins. But again, we're just focusing on the MDR ones right here. And again, here we have another example. We have the enterocytes where they are using PGP to pump drugs from the blood out through the GI tract in order to help prevent them from being absorbed. So again, if you have an issue where you're having an inhibition of this protein, you're going to be decreasing the amount of efflux you're having. Thus, you end up having higher blood concentrations of the drug that can lead to some pretty significant interactions, as I mentioned in the previous slide. A couple other ways that drugs can be absorbed include endocytosis. So this is for substances that might be very large, lipid insoluble, or just otherwise impermeate to the cell. And so basically this is a process in which the substance is engulfed by the cell membrane and then carried into the cell by pinching off this new vesicle within the membrane. So a couple examples of where this occurs is going to be with absorption of things like B12 and also iron from getting absorbed from the GI tract. Exocytosis is basically going to be the opposite process where the cell is going to have secretory vesicles that basically forces them out as they join the membrane. And so some other examples of this would be things like enzymes being released from the pancreatic cells that produce their hormones from the endocrine glands, and also calcium in the bloodstream. So here, just a picture kind of showing you the process of exocytosis, where here on the right side you're seeing molecules being released from this vesicle as it joins the membrane here, and then something being absorbed by endocytosis, where this is being kind of pinched off from the membrane to form a new vesicle. We won't talk about this too often with a lot of medications, but just for completeness sake, we'll mention it here. So the next thing we'll talk about, we talked about absorption, how the drugs get into the body. The next thing we'll talk about is this distribution of the molecules within the body. Once it gets into the central circulation, where does it go from there? And so one of the big definitions we'll talk about is going to be volume of distribution, otherwise abbreviated as VD. And so this is kind of a fuzzy topic that a lot of students have a hard time kind of grasping at first, but hopefully I'll show you some examples and give you a good idea what this means. If you do have any problems or questions about it, please feel free to send me an email. I'm more than happy to clarify further because I know this is kind of a tough topic for some people. So volume of distribution is going to be this apparent volume that a drug would have to occupy to give the same serum concentration as measured within the body. I'll show you what that means in just a second, because that definition is not very good. I would totally agree with anyone that would criticize that, but it's the definition nonetheless. This means it's a theoretical number, and what it's really trying to do is to describe how extensively a drug is distributing into the tissues, right? So you basically have kind of two places for the drug to go to, just to simplify things. You either have the central circulation, the bloodstream, or you have the tissue. And so drugs that are able to highly distribute themselves from the bloodstream into the tissues are going to have a high volume of distribution versus things that like to stay within the central circulation or stay within the blood. They're going to have a relatively low volume of distribution. So some of the ways that we'll talk about this are going to be with a couple different math equations that'll help us out here. So looking at how we can figure out or calculate a volume distribution, here you'll see the VD, which is oftentimes you'll see measured in liters, will equal the total amount of drug within the body, usually in milligrams, divided by the concentration of that drug within the plasma. Usually measured in milligrams per liter. Here we'll just keep all of our units similar. So again, the concentration in the plasma is really going to depend on how far that drug is being distributed out. So what we'll see here is that for drugs that have very high distribution, drugs that like to really distribute themselves out to the tissue, you're going to have a relatively low concentration within the plasma. It means your denominator is going to be smaller, which is going to make your VD bigger, right? And the converse is true as well, where things that have a low volume of distribution are going to have a relatively high concentration within the plasma, and thus they're going to have a bigger denominator and thus a smaller VD. So another way that we can calculate this is going to be looking at our VD is going to equal our dose, our D, which is going to be the total drug in the body, divided by C0, which is going to be the concentration of drug in the plasma. So say, for instance, I were to give someone a 25 milligram dose of a drug that was administered via IV, right? So I basically inject this directly into your vein, so you know there's 100% absorption, so it's not really figuring into it. And I know so that's the total amount of drug within the body. and then I immediately measure a plasma concentration, and that comes back at 5 milligrams per liter. Now, if I were to divide that out, you'd see 25 milligrams divided by 5 milligrams per liter. You're basically going to get a volume distribution that equals 5 liters. What we'll see is that high volume distribution usually indicates that a drug is lipophilic, and thus is going to have an easier time crossing those lipid membranes, and is going to be more distributed extensively throughout the body. There's some rare circumstances where that's not the case, but this is going to hold true for nine times out of 10. I'll give you some more examples of calculations to kind of show you comparison between things with low volume distributions versus things with high VDs. So look at this example here where basically I have two drugs. I'm going to have drug A, then I'm going to have drug B. We'll see that drug A is going to be hydrophilic, meaning that it's not going to have a very easy time crossing lipid membranes, which means that it's going to like to stay preferentially in the central circulation. So it's going to like to stay in the blood. On the other hand, you're going to have drug B, which is going to be more lipophilic, meaning it has an easy time crossing blood-brain barrier, or crossing lipid membranes, and this is going to have an easier time distributing out into the tissues, and so it's going to like to stay out in the tissues more versus the blood. Now say I have two people, they're identical twins, so they should have the same weight, same height, same physiological characteristics, and I'm going to give one of them 50 milligrams of drug A, and I'm going to give the other one 50 milligrams of drug B. So the D here is going to be the same between the two drugs, right? Because the total drug in the body is going to be 50 milligrams. Now, if I were to measure concentration of the drug A in the first twin, what I'm going to see is that the concentration is 10 milligrams per liter. So if I were to divide that out, my VD is going to equal 50 milligrams, which is my dose, or D, divided by 10 milligrams per liter. It's going to equal 5 liters. If I do the same thing for drug B in the other twin, I'm going to get a concentration of 0.5 milligrams per liter. So going back to that, you see our denominator is a lot smaller here than what we see for drug A, and that means that I'm actually going to end up getting a VD that's going to be 100 liters. So essentially what that's telling you is that the drug is distributing out to a much higher degree. You're going to have a lot more drug located within the tissue versus just located within the blood. So to kind of give you a visual representation of what that looks like, the thing that has low volume distribution, only 5 liters, versus something that has 100 liter volume distribution, it's just going to be partitioning itself out much to a higher degree than the low volume distribution drug. So just to give you some examples of different drugs and their different volumes distribution, what you'll usually see is that this is oftentimes going to be expressed in terms of X liters per kilogram. And then you would just, to figure out what the actual volume distribution would be, you just multiply it by whatever your patient's weight is. So say, for instance, you have someone who has, who weighs 70 kilos, and the volume distribution is 1 liter per kilogram, and that person's volume distribution would just be 70 liters, right? So you can see things can have a very low volume distribution. So something like heparin, say only 0.05 to 0.1, which means that it's going to like to really preferentially stay within the central circulation, which is a good thing because heparin is an anticoagulant. We want it to work on the blood. We don't really need it to work out in the tissue. We're not really worried about it there. And then you can have things on the complete opposite end where you have things like digoxin, which can have very high volume of distribution, say 2 to 5 liters per kilogram. Chloroquine has an extremely high volume of distribution, 200 liters per kilogram, which means that you're going to definitely find a relatively low concentration of the drug within the blood. But if you were to do a tissue concentration, you see that it's much higher. And so volume distribution also gives us a decent idea of how hydrophilic or how lipophilic a drug is. So things that have low volume distributions, again, tend to be more hydrophilic. Things that have high lipid solubility or more lipophilic tend to have higher volumes of distribution. So again, looking at something like nortriptyline, you definitely say that's going to be more lipophilic than something like atenolol, just based on looking at the volume distribution of the drug. So just to give you another example here, so we can actually, based on the established volumes of distribution of a drug, we can actually use this data to estimate what a person's drug level would be if you were to measure it. So say, for instance, you have a 70-kilogram man, and you have a dose you're going to give him, IV, of 100 milligrams of drug C. Now, based on previous studies, we know that drug C has a volume distribution of 0.6 liters per kilogram IV. And just as a general rule of thumb, things that have a volume distribution less than 1 liter per kilogram tend to have be kind of considered low volume distribution drugs. Things that are greater than 1 liter per kilogram are generally classified as things that have high volumes of distribution. But using this, we can actually estimate his plasma concentration of drug C. So looking back at our equation, you can see here that our volume of distribution equals our drug, or dose, over C0. So in this circumstance, I'm going to have 70 kilograms times my volume of distribution of 0.6 liters per kilogram is going to equal 100 milligrams, because that's my dose, over C0. And this is what I'm trying to solve for here. If I multiply that out, I'll see the 42 liters is my actual volume of distribution when I give it to that patient, is going to equal 100 milligrams over C0. If I rearrange that, I'll see that my C0 is going to equal 100 milligrams divided by 42 liters is going to equal 2.38 milligrams per liter. So what that means is if I give this 100 milligram dose to this 70 kilogram man, if I were to measure his blood level, I should get something approximating 2.38 milligrams per liter. And this is useful because that way you can at least have a decent idea of what dose you should give someone in order to achieve a certain concentration. Because as we saw previously, we know that drug concentration is usually a surrogate for how much drug is going to actually be at the tissue, which is going to be at the receptor site to be physiologically active. So by doing this, if I say, well, my target concentration is between 2 and 3 milligrams per deciliter, I know that 100 milligrams would be an appropriate dose for this size patient because I know I'll achieve a concentration between 2 and 3 milligrams per liter. Moving on, next portion after the absorption and the distribution is going to be our metabolism. And so this is going to be the mechanisms that will terminate or alter the biologic function of a substance. And so the main function of metabolism is that it's trying to prepare the substance for elimination. And so a lot of things are not, when they get absorbed, they had to be lipophilic to some degree in order to be absorbed, but they're not really set up to be excreted either by the kidneys or through the bile. So the metabolism that happens here is, in general, going to make something more polar. So it's going to be more likely to be filtered by the glomerulus in the kidney or to be processed through another elimination route. And so what you'll see is that for the most part, these metabolic reactions are normally going to deactivate the molecule. In some cases detoxifying it, especially if you're having a toxic reaction to certain drugs. But essentially you should be leading to a less pharmacologically active product. This isn't always the case, but in general, you're going to be seeing things that are going to be made more polar, and they, in general, will be less active. One other definition to point out here is the concept of a prodrug. A prodrug is basically going to be a little bit more professional than, say, like an amateur drug. Just kidding. A prodrug is actually going to be an inactive substance that has to be converted via some metabolic pathway before it actually has its biologic activity. So some good examples of this would be things like ACE inhibitors or angiotensin converting enzyme inhibitors. These are most often used as antihypertensives. The drug that we give orally, one of them is called enalapril. Well, enalapril doesn't really have any good antihypertensive function itself, not until it's being converted by the liver over to enalaprilat. That is the actual physiologically active component of the drug, which can have this antihypertensive effect. I mentioned this previously, but the analgesic codeine gets converted over to the more potent medication morphine to have its analgesic effect. And then another good example that you see used a lot for attention deficit hyperactivity disorder would be lisdexamfetamine. Brand name is going to be Vyvanse. This one actually is a prodrug that gets converted over to dextroamphetamine, which is a stimulant that helps to increase focus and attention and things like that. The interesting story with Vyvanse is that there is a lot of abuse potential behind amphetamines. Obviously, they're controlled substances and narcotics. They have addictive potential. And so what was happening with some of these amphetamine-based ADHD drugs is that patients were crushing them and then snorting them in order to achieve, instead of getting a dose metered out over 12 hours, they get all the big dose all at one time, get a pretty decent high out of it. Well, what happens with Vyvanse is that if you were to crush and snort this lisdexamfetamine, because going via the nasal route bypasses the liver's first pass function, like we mentioned before. Um, Not a very big percentage of it gets converted over to the physiologically active component. So you could snort it and you really wouldn't get a high out of it. And so it was really done to discourage abuse of the medication. If you take it normally orally, you get it absorbed through the GI tract, goes through the liver, gets converted over to dextroamphetamine where it can be physiologically functional. So just a good example of using a prodrug in order to help limit abuse of a certain medication. You'll see that metabolism of medications occurs primarily within the liver, but it's not exclusive to that organ. You can see metabolism of drugs occurring within the lungs, to some degree the GI tract, the skin, the kidney, even the blood has certain enzymes in it, like hydrolases and things like that, which can metabolize certain substances. Again, we'll see that enzymes within the liver function to change drugs over to their metabolites. So you'll see that as a pretty big term we'll use moving forward. And then the basic goal here is that we're converting these xenobiotics into more water-soluble components where they can be excreted. And there's a couple of different processes where this occurs, and we'll talk about these in either being in phase 1 reactions or phase 2 reactions. Now, one of the big things that some people will get hung up on is that not every drug has to undergo a phase 1 reaction and then a phase 2 reaction to be excreted. Some drugs will undergo just a phase 1 reaction and be excreted. Some will undergo just a phase 2 reaction and be excreted. Some will undergo both phase 1 and phase 2 reactions. So they're not mutually exclusive from one another. But in general, most things will undergo a phase 1 reaction and then either be excreted from there or undergo a phase 2 reaction where they'll be excreted from there at that point. So phase 1 reactions will be definitely one of the more common ones that we'll be talking about. And again, these are really working to either introduce or uncover a polar functional group that provides a good site for phase 2 metabolism to occur. The major classes of reactions we can see here include things like oxidation, reduction, and hydrolysis. Lots of different phase 1 enzymes are responsible for this, but includes things like cytochrome P450, which is the biggest one that we're going to talk about and the most important one to remember for testing purposes, for sure. But you can also see things like flavin monooxygenases, monoamine oxidase, which is important for catabolism of things like neurotransmitters, esterases, hydrolases, and all of that. Again, cytochrome P450 is probably the one that we'll talk about most just because of the fact that there's so many drug interactions that occur with it. Now, phase 2 reactions, once you have a functional group that's been either uncovered by phase 1 reaction or the drug itself has a suitable location for it, you'll see that phase 2 reactions will either add or alter the molecule to increase its water solubility. So the addition component here is the big one we'll focus on, because usually you're going to have the additional molecule added on, like either a conjugation of, say, something like glutathione. You can have glucuronidation or sulfation to occur to make the drug more water soluble for excretion. So just looking here at this process, again, not every drug is going to go through phase 1 and phase 2. Some will undergo just phase 1, some undergo just phase 2, just depends. But again, here looking at this process here, you can have things like your CYP enzymes. They'll be working to produce phase 1 metabolites, which again can be excreted from here. Here you can see that the phase 2 process occurs where you can have things like glutathione added on to a molecule. You can have sulfate groups added on, amides, and other things like that, where eventually they can be excreted as well. A good example I like to use, especially from a tox standpoint, is acetaminophen, because it undergoes so many different metabolic pathways. So say right here you have acetaminophen, the molecule itself. Notice here it already has a hydroxyl group here where it can be reacted with. Now, a large proportion of the molecule will undergo this glucuronide conjugation, where it'll add on a glucuronide molecule. So this would be a phase 2 reaction here, where it can then be eliminated through the kidneys. You'll also have sulfation that can occur to a large degree as well. We have the sulfate group added on. Again, this would be another phase 2 reaction where it can then be excreted in the kidneys. Now, a smaller proportion of the drug itself will undergo reaction with cytochrome P450 isoenzyme 2E1. So this would be abbreviated CYP2E1. And what actually gets formed here is this reactive intermediary called NAPK. Again, you don't have to memorize this entire process. This is really just more for illustrative purposes. But this NAPK is actually a very toxic component. This is what causes a lot of the hepatotoxicity you see in acetaminophen overdose. What the body can naturally do, though, because you have 62% going through glucuronidation, you have 36% going through sulfation. Usually a very small component of this undergoes CYP2E1 metabolism, but whatever small amount of it does end up producing this NAPK. You do end up having glutathione conjugation here, where you can have basically glutathione added on here to the molecule, where they can then be further metabolized and then excreted. What ends up happening when you have an acetaminophen overdose is that what you can actually end up doing is overwhelming these pathways, where you basically you basically deplete your body's stores of glucuronide, you deplete the sulfate donors here, and so you end up having a higher proportion of the medication undergoing this pathway, the 2E1, and then you end up overwhelming this glutathione conjugation step here, to where you just have a whole lot of this NAPK that is not able to be metabolized, and this can cause hepatotoxicity and lead to death eventually. So again, just another slide showing some common metabolizing enzymes here. Again, it's not important to memorize every single one, but just know that you'll see these in different examples of metabolizing various drugs. So again, most common ones we're going to be talking about are going to be the CYP P450s. You also see glutathione transferases will be important, sulfonyluretransferases, things like that. And then also important for things like ethanol, you'll see alcohol dehydrogenase and aldehyde dehydrogenase, which are important for that process as well. So we've mentioned this before, but there's this concept of a first pass effect, where a certain proportion of drugs that are metabolized or that are being absorbed through the GI tract will end up paying this liver tax, essentially, where a certain proportion of it will be metabolized by the liver before it gets introduced into the central circulation. And again, this metabolism is occurring via these liver enzymes. And so in a lot of cases, the concentration of the drug will be reduced to some degree before it reaches the systemic circulation. And it's really going to vary based on the medication you're dealing with. So certain drugs cannot be administered via the oral route because the liver metabolizes to such a large degree. Other drugs can get through with relatively no metabolism occurring. Ethanol, as we mentioned, is a very good example of this, to where you have a certain proportion of it being metabolized by the liver when absorbed orally. But say I were to give ethanol by a different route, say I were to inhale it. There are certain devices out there which work to aerosolize the ethanol to allow it to be inhaled. Well, you bypass your first pass effect here, and thus you can absorb a higher proportion of the alcohol. If you were to rectally administer alcohol, again, same thing happens here, where you're bypassing the liver's first pass effect, and thus you're getting a higher blood concentration than you would if you'd taken the same amount orally, which can lead to some pretty significant toxicity associated with that. Get a lot more alcohol than what you'd bargained for based on the dose you administered. Now, as we mentioned, the cytochrome P450 system is going to be the most important phase 1 reaction system that we'll talk about. This is really important for lots of different functions, including endogenous biosynthesis and catabolism, metabolism of a majority of drugs. And you'll also see that it has an important role in determining the intensity and duration of action of drugs. So the more extensively it gets metabolized via the CYP enzymes, the less intensity and duration it's going to have, because the drug gets metabolized more quickly, and vice versa. And we'll also see that many things can interfere with the cytochrome P450 system, either to inhibit it or to actually induce it and make it have a stronger function. And thus it's very, very important in lots of different drug interactions. So there's lots of different P450 enzymes that are out there. There's been more than 1,000 individual enzymes identified, and we know there's more than 50 functionally that are active within humans. Now, the human cytochrome P450 enzymes, oftentimes will have multiple forms or isoenzymes, and we'll see that each of these are going to be encoded by a separate gene. And again, based on different influences, you may have inhibition of this translation, transcription, or you may have induction of that process. But essentially what we're going to be seeing is that you can categorize CYP450 enzymes via their family and subfamilies down to the individual amino acid sequence. So for instance, we have here CYP2D6, and we mentioned this one being important in metabolizing codeine, the narcotic analgesic, over into morphine. So CYP2D6 would be the enzyme name. The CYP basically identifies it as a cytochrome P450 enzyme. We know 2 would indicate the family, which means that it would have greater than 40% homology with other CYP2 family enzymes. The D would be the subfamily, meaning it would have greater than 55% homology with other 2D enzymes. And then 6 would be the individual enzyme itself, so the individual unique sequence. So you can have 2D6, you may have something like 2D5, but you'll see that certain ones will emerge as being the most common ones that you'll be dealing with from a medication standpoint. Just to kind of show you the process for what's occurring when you have a P450 working on a molecule. Again, this is an oxidation pathway. Again, it's not important to memorize this entire slide, but basically when you have this introduction of a drug here, again, you're oxidizing it, oxygen being introduced here, and eventually this hydroxyl group will end up being uncovered on the drug itself and where it can be released. And again, from here, it can undergo further metabolism via phase 2 reactions, or it can be eliminated via the kidneys or whatever organ is responsible for eliminating it in the first place. So just for people that are curious about the actual process that occurs when P450 is interacting with these drugs, this is what's happening. So another slide you don't have to memorize, but just to give you some examples of some of the substrates for different common CYP450 enzymes, inducers, and also inhibitors. So we'll see that lots of different enzymes will kind of show up as being the most common ones for metabolizing different enzymes. So one of the biggest ones you'll see here, and it's pretty obvious based on just the number of drugs here, and this is not totally inclusive, but 3A4 is going to be one of the bigger ones you're going to be dealing with on a clinical basis. 3A4 is really responsible for the majority of drug enzymes that are hepatically metabolized, and so it's very important to be aware of this and to know what certain inducers are going to be. Meaning inducers are going to be ramping up the number of 3A4 enzymes that are available, thus it's going to have the ability to metabolize drugs more effectively, thus it's going to limit the total body exposure to a drug. So drugs will be metabolized more quickly unless you're going to have less exposure to the drug, meaning things may be less efficacious because they're being metabolized more quickly. So things like barbiturates, which are anti-epileptic drugs, things like phenytoin, which again is another anti-epileptic drug, can induce 3A4 to metabolize these enzymes more quickly, or these drugs more quickly. On the other hand, you can have inhibitors, which means that drugs will be metabolized less quickly, thus you can end up having buildup within the body, have total increased body exposure, and can lead to toxicity. So especially things like fluconazole, grapefruit juice, which have these certain furanocoumarins in them, ketoconazole, ritonavir. This is actually a really important interaction for HIV medications. These would lead to higher total body levels of these medications and thus predispose you to toxicity. Other enzymes that are important would be 2D6. These are going to be, I always remember this one as being important for medications that affect the head and the heart. So you'll see a lot of CNS medications, a lot of antidepressants and things like that being affected by this, and also certain medications for the cardiovascular system, so things like beta blockers. Some are metabolized by CYP2D6. Other big ones you'll see would include things like 2E1, 2C9, but really 3A4 is going to be the one that has the majority of interactions that you need to be clinically aware of, just due to how ubiquitous it is in metabolizing these drugs. Again, this is a nice slide that kind of shows you the various CYP enzymes here in this top pie chart, and shows that CYP3A4 is really responsible for near half of the metabolism that occurs via CYP enzymes, or these phase 1 reactions. You can see it, 2D6 is another large one, 2C8 and 9 is an important one as well. 2E1, even though it doesn't metabolize a lot of drugs, the drugs are common enough to where they do become clinically significant. And then on this bottom pie chart here, you have phase 2 reactions and how those kind of get broken up. It's a little bit more kind of evenly split between them. Nothing too important to take away from this pie chart here. Some other places where drugs can be metabolized than the liver would be places like the gastric acids. So we'll see that certain medications are not really able to be well absorbed because they get broken down by gastric acids, preventing them from oral administration. Certain digestive enzymes that are released by things like the pancreas can be important here. Even enzymes within the intestinal wall all can help to decrease the amount of absorption you can have. It's also important when talking about gut flora as well. They are a significant source of metabolism for certain medications. This can be clinically important for a big number of patients, especially if they are altering their gut flora. So a good example of this would be vitamin K absorption in interaction with a drug called warfarin or Coumadin, which is an anticoagulant. It works as a vitamin K antagonist essentially, and vitamin K is really important for producing clotting factors that help you to maintain hemostasis. So if you have someone who's on warfarin, it's really important for them to stay on a stable amount of vitamin K that they're absorbing, because if not, then you may be inhibiting that too much, and that's predisposing yourself to bleeding because you're not producing enough clotting factors. Well, the gut flora is really important for metabolizing vitamin K and activating it and allowing it to be absorbed through the GI tract. So say, for instance, if I have an infection and I start to take an antibiotic, well, I can basically wipe out your entire gut flora with that antibiotic and lead you to have less vitamin K absorption, and thus now your warfarin may be too effective, leading to bleeding that can occur. So again, being aware of things like antibiotic interactions based on its interaction with the gut flora is going to be really important to keep in mind as well. Other things that can affect metabolism within the liver specifically can be liver disease, since it can help to impair the number of functional metabolizing enzymes that are available to metabolize these drugs. So certainly patients who have either acute or chronic liver failure can have issues where they're not producing enough enzymes. So if they have alcoholic hepatitis or chronic cirrhosis, anything like that can lead to a decreased ability for the liver to produce functional enzymes that can metabolize these drugs. You can also have issues where decreased liver blood flow can affect the ability for the drug to even get to the liver to be metabolized. So issues where you have renal disease, where you have a lot of extra fluid buildup, or you're impairing the ability for the venous system to transfer blood through the liver can be important here. So lots of renal disease can be important, and also cardiac disease as well. So if the heart is in a state of chronic failure and it limits the amount of blood flow getting to the liver, this can definitely lead to lower metabolism of certain drugs. So a good example of this would be a drug like lidocaine that is sometimes given intravenously for heart arrhythmia. If you have a patient who has congestive heart failure, this is actually be a case where you'd want to give half of the normal dose because you have less flow going to the liver and less drug being metabolized because of that. Other things that can affect metabolism, including endocrine changes like hyper or hypothyroidism, can either make metabolism more or less functional. Certain genetic factors can be important here as well. So certain patients may have either multiple copies of a gene for certain metabolizing enzymes. So you could have people who are rapid metabolizers. You could have impaired metabolism due to different genetic factors. So you can have poor metabolizers of certain drugs. Lots of things like diet and environmental factors can be important here as well. So things like charcoal broiled foods can actually induce certain CYP enzymes, whereas things like grapefruit juice might inhibit it. Right, so you got to be important to keep in mind your food-drug interactions here. Age and gender can be important here as well. So especially when we talk about our neonatal pharmacology, we'll talk about how newborns really have underdeveloped CYP enzymes and are not able to metabolize a lot of drugs very effectively because their livers just aren't that developed yet. And then any kind of disease that decreases blood flow to the liver can impair metabolism. So again, just to show you kind of the process that's occurring here. In pictorial form, again, once you have a drug that's absorbed and is in the central circulation, so you're going to be metabolized either through one of these phase 1 pathways, undergo phase 2 pathways as well. Again, once it's undergone a phase 1 pathway, if it's more polar, it may just be able to be eliminated from the kidneys itself without any further functional changes. Certain ones will end up going through the phase 2 reactions here, where they'll either be eliminated again through the kidneys, or they can be eliminated potentially through the biliary tract, and where it can actually have drugs that are eliminated primarily in the stool. Just depends on the drug itself and where it likes to be metabolized and eliminated from. So the primary organ we'll talk about in relation to elimination or excretion of medications is going to be the kidneys. And so we'll see that most drugs tend to be freely filtered in the glomerulus, but one of the big things that impairs the elimination of these drugs could be reabsorption within the renal tubules. So one of the things we'll see here is that reabsorption occurs when drugs are going to be more lipid soluble. So obviously, if something gets reabsorbed from the renal tubules, it goes back into the central circulation, where it can go and still be physiologically active. But one of the things we do see is that things that are charged tend to not be readily reabsorbed. Again, that goes right back to where we were talking about lipid diffusion previously in this lecture. This can be influenced a lot by the pH of the urine. So we can essentially do some ion trapping, where we can actually affect how well something is reabsorbed or not based on altering the pH of the urine. And so normal urine pH may range anywhere between 4.5 to 8, and so we'll see that this can have a big impact on drugs based on their pKa, whether or not they're weak acids or weak bases. So one of the things we'll see here is that weak acids are usually excreted faster in alkaline urine. And again, this goes right back to the old adage, like dissolves like. So if I put a weak acid into an alkaline urine, that means they're going to have a higher proportion of that drug being in the unprotonated state, which means it's going to be in the charged state, and thus it's going to be less likely to be reabsorbed because its lipid solubility is going to be lower. Whereas on the other hand, if you have weak bases that are in an acidic urine, you can actually put them in a more protonated state, and thus are more have a higher proportion of that drug having a charge, and thus it's less likely to be reabsorbed. And so, again, lots of places where drugs can be trapped based on the pH changes that can occur. So say, for instance, the breast milk is a good example to where breast milk may be more acidic than what the blood is. And so if I have a drug that gets filtered into the breast milk based on it having good lipid solubility, and it gets into a more acidic medium, say especially if it's like a weak base, it may be in a more protonated state, in a more charged state, where it can't really cross back over, and thus you can have drugs being accumulated within the breast milk. Same thing happens with prostatic secretions, aqueous humor, anywhere where you can have transfer these drugs into solutions with a different pH. So a good example where you can actually alter the pH of the urine to help increase elimination of a drug would be in the case of an aspirin overdose. We've mentioned previously that aspirin is a weak acid, and so one of the things that we can do to help increase elimination from the kidneys is actually by increasing the urine to the pH. By increasing that urine pH, I'm going to put more of the aspirin into an unprotonated state. It's going to be more charged, and thus less of it can be reabsorbed within the renal tubule, and thus it can be eliminated more quickly. And so most often we do this with sodium bicarbonate, where you actually give sodium bicarbonate IV, and that helps to increase not only the pH of the serum, but most importantly the serum or the pH of the urine to help trap the aspirin in the renal tubules and let it be eliminated within the urine. So regardless of how a drug is being eliminated, it all goes back into this kind of total clearance of the drug from the blood. And so this is usually going to be put in terms of mLs per minute, or certain volume of blood that's being cleared of the drug per unit of time. And so really this idea of clearance is describing the total elimination rate of drug being removed from the body. And so you have to kind of include all means of clearance, so looking at the renal clearance plus the liver clearance plus the biliary, blah, blah, blah. But in most cases when we're talking about clearance, you're mostly just looking at the amount that's being eliminated by the kidneys. Because for most drugs, that's where they're going to be eliminated from, and so you can usually get by with just looking at that. Like I said, for some drugs, they're going to be primarily eliminated through the biliary tract. That may not be the case, but we'll talk mainly about renal clearance for the most part for these purposes. So again, clearance is going to be really important for determining drug concentrations within the serum, because if a drug's not getting eliminated through any means, it's going to start to build up within the blood, which can lead to therapeutic concentrations, or if not cleared quickly enough, can lead to toxic concentrations. And so one of the things we're looking at is that renal clearance tends to correlate pretty well with renal function. And so the way that we can get a surrogate marker of this is going to be looking at our creatinine clearance. And so when we're looking at drugs that are eliminated via the kidneys, creatinine clearance is going to be a really good estimate for how well that person is going to be able to clear that drug. Creatinine, we know, is a byproduct of muscle metabolism that is, for the most part, produced at a pretty constant rate and cleared primarily by excretion through the kidneys. Normal serum creatinines, we'll see, can range anywhere between, say, like 0.6 to 1.2 milligrams per deciliter. It's going to depend on your patient. Certainly, patients have lower muscle mass may have altered serum creatinine levels, but this holds true for most adults. Obviously, someone who has poor kidney function will not be able to excrete the serum creatinine as well, and thus they're going to have higher serum creatinine concentrations. You can see here, patients who have, say, lower muscle mass, say like if you had an amputation, say like a leg, or if you are extremely elderly or extremely young, you don't have a whole lot of muscle mass, that's going to make your serum creatinine relatively lower. Now you can do creatinine clearance based on 24-hour urine collection. That's possible, but it's hard to get someone to actually collect their urine for 24 hours, and it can, again, takes 24 hours to actually collect that. So most often what we're going to do is measure creatinine clearance based on a formula. So that formula we use for most healthy adults is going to be the Cockcroft-Gault equation. And so the way we're going to calculate this is basically looking at the age of the patient. So you do 140 minus their age times their weight in kilograms, and then you would divide that by 72 times their serum creatinine. Because in general women have lower muscle mass than men do, you multiply this entire thing by 0.85 in order to get the creatinine clearance for a woman. So this kind of takes in, for most patients, this is going to be a pretty good calculation, and you'll see this is probably the most common one for most adults. You'll see that the weight can be something that can be skewed, especially if you have really obese patients. So in some cases, you'll use things like adjusted body weight. But for your run-of-the-mill 70-kilogram adult, you can get away with using this calculation, and it works pretty well as a good surrogate for what their actual renal function is going to be. Now, you'll see that different equations are out there, and they're going to be useful for different patient populations. So if you have someone who's at the kind of extremes of age, so children will have their own specific calculations that we're going to use, and the elderly will also have ones as well. But again, Cockcroft-Gault is the most common one for adults. So looking at what a normal creatinine clearance would be for men can typically range anywhere between 97 to 137. Now, you may have variations in that depending on your patient. Obviously, women, because again, they're producing less creatinine on an average basis, they're going to have an average lower creatinine clearance, which may still be totally normal for them. So clearance is going to be really important because it kind of works in conjunction with volume distribution to help us determine what the half-life of a drug is. We'll talk more about this in just a little bit, but half-life is essentially going to be the amount of time it takes to cut a drug's serum concentration by half. And again, the way this works is that clearance is basically determining the amount of drug that's being eliminated per unit of time based on the actual flow that's going through whatever organs is being cleared from. And then the volume distribution tells us the actual volume of blood that needs to be cleared of that drug. And so essentially what this is helping to do is that clearance helps us determine what the steady state plasma concentration of that drug is going to be. So I'm going to get more back to that in just a few minutes, but first we need to talk about elimination kinetics to help us determine certain factors like our half-life. So essentially when you have elimination of a drug, two main ways this can occur is either via first-order elimination or zero-order elimination. Now, the majority of drugs are going to undergo first-order elimination. And basically what this means is that you're going to have elimination of the drug that's going to be a constant percentage of drug per unit of time, or constant proportion of that drug per unit of time. And so this is going to be proportional to the concentration, meaning that the higher the concentration that I have, I'm still not going to have the same proportion of drug being metabolized. It will be a larger amount, but it's still going to be the same proportion. And I'll show you some pictures here in just a second that kind of illustrates this. On the other hand, I can have zero order elimination where I'm eliminating a constant amount of drug per unit of time. And so this will be independent of concentration. So it doesn't matter how high I get the concentration up, the speed at which I'm clearing that drug never gets any faster or slower. And so a good example of this would be something like ethanol, which we said on average for non-chronic user of alcohol, they would metabolize around 20 milligrams per deciliter per hour of ethanol on average. So I'll show you some comparison pictures here so we can get a little bit clearer idea of what first order versus zero order elimination is. Here, if we were to look at clearance on two scales, so we're looking at drug on our y-axis and time on our x-axis. If you were to look at zero order kinetics, again, like we mentioned, this is going to be a constant amount of drug per unit time. So for, say, ethanol, even if I'm here, have a very high concentration, I'm only going to metabolize 20 milligrams per deciliter per hour. 20 milligrams per deciliter per hour, 20 milligrams per deciliter per hour. Whether I'm at the top of the curve or the bottom of the curve, I'm still metabolizing the same amount of drug per unit of time. On the other hand, though, if I'm looking at first order kinetics, where I'm metabolizing the same proportion of drug per unit of time, the higher my concentration is per that unit of time, the higher amount of drug I'm going to be metabolizing. So you can see here that I'm going to have a very big proportion of drug metabolized in this first hour versus a smaller amount in the second hour, smaller amount in the third hour, and so on and so forth. So first order kinetics are going to be really important for affecting renal clearance of many medications. And we'll see that the concentration of the drug and the rate of drug administration are going to help to determine what that clearance is going to be. So essentially what we're looking at is when clearance is equal to the rate of administration, or the rate that we're actually giving the drug, divided by the actual drug concentration. And essentially what you're seeing here is that your clearance equals the dose divided by interval, which again is the rate of how quickly you're giving the medication over that drug concentration. So the key point here is that there's a proportional relationship. So even though I'm increasing my dose, if I give a bigger dose or bigger amount I'm giving into the central circulation, the clearance is going to go up proportionally with that. Doesn't matter because I'm always going to be metabolizing the same proportion of drug per unit of time. So a good example of this would be, say for instance, I give, say 1,000 milligrams of a drug to a patient. So at time zero, the amount of drug within the body is 1,000 milligrams, right? Because I haven't had any time to eliminate it. Now, if it's following first order kinetics, say for every hour, I'm going to be metabolizing or eliminating 15% of that drug. Right, so after 1 hour, I've eliminated 15% of that drug, so I have 850 milligrams remaining in the body. I've eliminated 150 milligrams. Now at the next hour, I'm not going to eliminate another 150 milligrams. I'm still going to eliminate 15% of that. So again, 15% of 850 is 127, so I eliminate that much. And again, every single time, I'm only eliminating 15% every hour. So it's the same proportion of drug per unit of time and not the same amount of drug per unit of time. Now, if this was 150 every single hour, then that would be a good example of zero order kinetics. But this is first order, since it's always the same fraction of drug being eliminated every unit of time. So basically a good way to help us determine what the half-life of a drug is, or how quickly a drug gets eliminated, we need to know what the elimination constant of the drug is. And so this can be represented by the term Ke. And so Ke represents the fraction of the drug that gets eliminated per that unit of time. So for that last example, the Ke would be 0.15. And so that's essentially the way we calculate the Ke is by looking at, say, a graph of a drug plasma concentrations over time. And with first order kinetics, as you remember seeing in that slide previously, you have that kind of that curve to it. When we're taking the log of the concentration, you end up seeing here it becomes a straight line. And so by using that log of the concentration over time and by using serial blood measurements, we can determine what the slope of this line is. And that slope is going to be what our Ke is. And so basically what we can do is by using different concentrations at different times, we can say use a peak level and a trough level, or it could be really any levels taken at different periods of time, and use the natural log of that divided by that change in time. So say I take a measurement here and I took another measurement here, I would take the natural log of this value divided by this value over this change in time, this delta time. And that will give me my elimination constant. Another way that you can calculate the elimination constant is by using Ke equals clearance divided by the volume of distribution, right? Because this tells us how quickly we're eliminating the drug that's in the plasma. This tells us how much volume of plasma we need to process in order to eliminate that amount of drug. So again, using these values can be handy because it helps us to determine what the Ke is, or what proportion of that drug is being eliminated over a unit of time. So going back to that term half-life that I used previously, so again, T1/2 is going to be the symbol we use there. Basically, it's going to be the time it takes for a drug's concentration to drop by half. So drug A, say, has a concentration of 20 micrograms per ml at 4 p.m. And then we do another measurement at 8 p.m. The concentration is 10 micrograms per ml. What would be the half-life? Well, it went from 20 to 10, so that's a halving of the concentration. So that happened over 4 hours. So that would be a 4-hour half-life. Another example would be drug B, which has an initial concentration of 40 micrograms per ml at 8 a.m. And then we do another measurement at 4 p.m. and we know the concentration is 10 micrograms per ml at that time. So what's the half-life going to be? Well, based on this, we saw that it's undergone two half-lives, because it went from 40 to 20 and then from 20 to 10. So that's 2 half-lives, and that was over an 8-hour period. So 8 hours divided by 2 half-lives equals 4. So again, this would be another example of a drug that had a 4-hour half-life. So to look at a graph looking at our half-life here, so say we're looking at the concentration here, not the log concentration, because you can tell by the curve still being this. This would be a drug that's having a first-order elimination, right? So here we can see the time, half-life, we'll say is 1 hour. So over 1 hour, the drug concentration went from 100% down to 50%. And then you see at the next hour, you're going to again have another, the same proportion of that drug being eliminated, half, happening here. Another half-life, another half-life, another half-life, where you have virtually getting close to 0 each time you do that. So again, half-life can be very variable between drug to drug. So looking at something like adenosine, which is a antiarrhythmic used for supraventricular tachycardias, has a half-life of less than 10 seconds. On the flip side, you can have drugs like amiodarone, which is another antiarrhythmic, that has a half-life of anywhere between 26 to 107 days. So again, you have anywhere in between these two extremes can be your half-life for different medications. So how do we calculate the half-life of a drug? Well, you could do measurements, and get them right at when the concentration half. But a lot of times you don't do that. A lot of times you get levels from a patient, and it could be 10, and then the next one could be 2. And that doesn't really give you the ability to really figure out what the half-life is based on that. What we can do, though, is by using the Ke, and we can figure that out based on drug levels, right? Because we can do that natural log of the peak minus divided by the trough over that delta time. If we take 0.693, divide that by the Ke, that actually will give us our half-life. Another way that we could look at that is that because we know that Ke equals our clearance over our Vd, we can substitute that in to say that half-life equals 0.693 times our volume of distribution over clearance. So based on that, we can kind of make some jumps in logic based on drugs clearance and Vd, what effect that's going to have on our half-life. So based on what we know, what if I were to change a drug's volume of distribution? What if I were to say give a drug a larger volume of distribution? What effect would that have on half-life? And remember, if I were to give something a larger volume of distribution, that means that I'm causing it to partition more extensively in the tissue, and thus less drug is actually within the central circulation. Well, if I increase that volume distribution, it's going to make my half-life longer, meaning it's going to take a longer period of time to eliminate that drug by 50%. Which makes sense because if I have more of that drug sitting out in the tissue, not enough of it's in the blood, or not as much of it's in the blood where it can be eliminated by the kidneys or wherever it's going to be eliminated from. Now, what if I alter the clearance? What if I said, okay, well now the patient has some degree of kidney injury, now they have a smaller clearance. What effect does that have on half-life? Well, because it's in the denominator, having a smaller value in your denominator is going to give you a larger half-life, which makes sense. If my kidneys are not functioning appropriately, I can increase, it's going to take longer for me to clear that drug, thus my half-life is going to get longer. So keep these relationships in mind because you're going to see changes in the volume of distribution and clearance of a drug based on lots of different factors like serum proteins, different disease states, renal function. All these things are going to be important because that's going to have a direct effect on your half-life. Another concept that's going to be important when discussing things like half-life is going to be steady state. And so this is going to be the state at which the amount of drug that I'm giving to a patient is going to equal the rate at which that drug is being eliminated. So again, it's going to be this kind of equilibrium where I'm giving as much as I'm eliminating in a certain period of time. And so clearance is going to be a major factor on this because this is going to be the proportionality constant that makes the average steady state plasma drug level equal to that of the rate of the drug administration. And so looking at your steady state level that can be calculated, which is abbreviated as CSS, or concentration steady state, is going to be equal to my dose divided by my clearance times my dosing interval. So since we know that steady state concentration is going to equal our dose divided by clearance times our dosing interval, what effect do you think that changing the dose would have on the steady state concentration? So if I were to give a higher dose, based on this calculation, you would see that, okay, well, that makes sense. I would have a higher steady state concentration. Because again, I'm administering more, thus because I'm undergoing first order elimination kinetics, presumably, and given the fact that the more drug I give, the higher amount of drug will be metabolized, because it's always the same proportion of drug being metabolized and eliminated. You'll see that by increasing the dose, you'll see that the CSS concentration is going to go up. But what would happen if I were to increase the dosing interval? Now, when I say increase the dosing interval, that means, say, instead of giving a medication every 8 hours, I'm going to give it every 12 hours instead, meaning that I'm going to have more time for that drug to be eliminated, right? So if I'm increasing my dosing interval from, say, 8 to 12, what is that going to do to my concentration, my steady state concentration? Well, since I'm making my denominator bigger, that's going to make my steady state concentration go down, right? Because I have more time for the kidneys to eliminate that drug. Thus, I'm going to have to give a bigger dose in order to compensate for that if that was the case. So in general, it takes roughly a drug, if I'm giving a steady constant dose, it takes roughly 4 to 5 half-lives in order for that drug to reach a steady state concentration. So I'll show you some graphs here in just a second to kind of give you a little bit better idea of what this really means. So in this situation, I would be giving a drug via continuous IV infusion. So looking at the concentration versus time here, I could see that at steady state, my input rate should equal my elimination rate, right? That's the constant or the equilibrium that we've hit. So if I were to give someone a constant IV infusion, you can see here the concentration would start to go up pretty rapidly, and at some point I would hit a steady state, to where the amount of drug I'm putting into the person's vein is going to be the same amount that's being eliminated via the body, right? So this would be my steady state, and again, this takes roughly 4 to 5 half-lives in order to hit the steady state amount. Now, if I were to increase my dose, based on what we know previously, you would see that the steady state concentration would actually go up. If I were to change my clearance and say clear the drug faster, say my kidney function improved, you would see that clearance would be increasing the denominator, thus making the steady state concentration lower, right? So again, this equilibrium here is a steady state we're talking about. And if I were to end the infusion, all of a sudden you see a rapid drop off, and then as the levels would eventually reach back down to 0 as I eliminate the final amounts of drug. So that would be for a continuous IV infusion. And again, because that's pretty inconvenient to do, we oftentimes are not administering drugs via continuous IV infusion. But this is kind of like the ideal situation. Now, say for instance we were going to be giving a patient oral doses. Same thing happens. We're still going to be hitting a steady state. It's just the graph would look a little bit different. So here again we're looking at concentration on our y-axis, time on our x-axis, and again this is going to be multiple administrations of the drug. So I give an oral administration. Say the dose is going to jump up, and after a period of time, once I hit my peak levels, eventually I'm going to start to metabolize that drug off before my next dosing interval. So I give a dose, pops up, and then the next dosing interval, since I haven't metabolized all of that drug yet, I'm going to see my levels start to go back up again, and then I'm going to start to metabolize that off. And then I hit my next dosing interval, and the levels go back up. And again, after roughly 4 to 5 half-lives, I'm eventually going to hit a steady state to where I'm administering a dose, metabolizing some of it, and then I'm administering another dose. And your average level here, this average steady state concentration, is going to roughly hit an equilibrium. So as long as my dose stays the same, as long as I'm administering it at the same interval, and my clearance doesn't change, I will always maintain that steady state concentration. Again, this would be an average, so even though I may measure the level at different times, it would always average back out to the steady state, assuming all the factors stay the same. So now we'll talk a little bit more about steady states, dosing frequency, and also achieving toxic concentration. So we'll come back to this graph in just a second. So if I were to administer a medication, again, we're looking at fixed dosing versus fixed interval administrations of a drug. So looking at, for instance, at this left graph here, again, we have our concentration of the drug on the y-axis here. We have time. Now, if I were to give a medication via continuous infusion, again, say 2 units of drug per day. Again, I'm going to see that similar graph to what we saw previously, where eventually you hit that steady state concentration. And again, you're going to be maintaining this regardless. So as long as I'm still administering that same dose at the same rate, I'll always maintain the same level, right? But again, continuous infusions are inconvenient. It's difficult to do. So oftentimes drugs are given intermittently. So say, for instance, instead of giving a drug continuously, I'm going to give it as intermittent doses. Let's say, for instance, I'm going to give the drug, 2 units of drug just one time daily. So instead of giving it 2 units of the drug over 24 hours, I'm just going to give it one time a day. And so what you end up seeing here is that you're going to getting really high peaks of the drug. You end up getting some metabolism down, and then the next day comes along, and then you have another really big dose of the drug, and it's going to come back down again, another really big dose of drug. At a certain point, after that 4 to 5 half-lives, you're still going to maintain the same average steady-state concentration. It's just that you're going to have these big fluctuations between when you dose the drug to when you get down to the trough and you redose it again. But the average steady-state concentration is identical to the continuous infusion. Now, on the other side, let's say that this doesn't really work for me because I'm given these really big doses, and when I start to get up to this level, I start to get toxicity. I start to get really nauseous, or get itchy, or whatever it happens to be. This is really intolerable. So one of the things I could do instead is to give the drug at a lower dose, but I can give it more frequently. So this white line here is going to be given 1 unit of drug twice daily. So instead of giving 2 units one time a day, or giving 2 units over a 24-hour period, I'm going to give 1 unit of drug twice daily. So here you see the concentration, the peak levels are not as high. I also see that our trough levels don't get as low because, again, we're going to be dosing it again at a more frequent interval. So you see here that, again, the average steady state concentration is going to be exactly the same. You just have less fluctuation than you would if you were given the drug once daily. And so we'll talk about certain instances, things like antibiotics, where this can become much more important. We'll talk about mitigating toxicity because by achieving kind of more tight control. Obviously, it's convenient to give a drug one time a day, but it may not be useful from a clinical standpoint or from a patient preference standpoint to do so. So just be aware that it doesn't matter how I give it, as long as I'm giving the same amount of drug per unit of time. It doesn't matter how frequently I'm giving it. I can still achieve the same steady-state concentration. It's just a matter of how much fluctuation I'm going to get. Again, same thing can happen with oral dosing. Again, repeated oral dosing, you're going to see these oscillations that occur, but eventually at that 4 to 5 half-life mark, you're going to hit a steady-state average concentration here. So what if I have a drug that has a really long half-life? Like we saw amiodarone can have a half-life of, say, 27 to 100 and some odd days. That 4 to 5 half-lives, that could take a long time. That may be over a year. So one thing we can do to mitigate the time it takes to get to steady state is to give a loading dose. A loading dose is essentially a bolus dose that will raise the plasma concentration to the desired level, to our predetermined steady state, and then after that we can give maintenance dosing in order to help maintain that steady state concentration. So again, if you look over here on this graph, you can see the red line here is going to be the concentration due to a loading dose, and then you can see the concentration due to the infusion. This black line being basically our steady concentration of the drug, right? So with, say, a drug I'm going to give a loading dose of, I'm going to bump up this concentration really high immediately. So I give this drug via IV bolus, and then get the steady state concentration right off the bat. And afterwards, I start up a continuous infusion in order to help maintain that steady state concentration. So as I'm metabolizing off the bolus, that steady state infusion, you see here the concentration is going to start to go up to where I had never a drop in my steady state level here. I always maintained a constant level. And so this is really useful for drugs that have a long half-life in order to help get you up to a steady state level much more quickly. And so the way we can figure out what our loading dose is going to be based on our volume distribution of the drug and also the total concentration that we want to reach. Again, remembering that C0, or that initial concentration, is equal to dose over VD. We can look at some different factors there. So again, total concentration is going to be taking into account peak concentrations. It's going to look at things like bioavailability and other factors. Certainly you can orally load drugs, but probably you'll see more frequently that drugs will be administered. Loading doses are administered via IV route. So good examples of this would be something like lidocaine being given for ventricular fibrillation. You would end up giving a bolus dose IV push followed by a continuous infusion. A good oral example would be a drug like azithromycin, which is an antibiotic, in which you would give 2 tablets on the first day to help achieve a steady state concentration right off the bat, and then you'd give 1 tablet daily thereafter in order to help maintain that. This 1 tab daily would be considered what we call a maintenance dose. It helps to maintain drug levels at that steady state concentration. So as I said, our maintenance dose is the dose we give in such a way to maintain steady state levels, and we can figure out what our dose is going to be to help maintain steady state levels by using that same calculation we looked at before. So if we know that our steady state concentration is equal to our dose over our clearance times our dosing interval, if I rearrange that, I get that our dose is going to equal the steady state level times our clearance times our dosing interval. And so keep in mind that the factors we do have control over versus the ones we don't. So again, if I have a steady state concentration that's pretty well, laid out within established guidelines or whatever it happens to be, that's what I'm going to be shooting for, right? The clearance we don't really have any effect over because it's going to all be depending on the patient's organ function, right? So if their kidney function is terrible, clearance is going to be fairly low. The things we do have control over is going to be our dose and also our dosing interval. So whether I get things more frequently or less frequently will have a direct impact on the type of dose I need to give. So here would be a good example of a drug. I believe this is for clopidogrel, which is an antiplatelet agent that's oftentimes given after heart attacks or after stents have been placed in order to help prevent clot from forming. This would be a case where I'm just going to focus on this top line here, where essentially you start out by giving loading doses of the drug in order to help get the concentrations high and achieve your steady state levels, whereas over the course of several days you'll see the maintenance dosing being given in order to help maintain the steady state concentration. So again, looking at our pharmacokinetic variables, again, given that steady state concentration equals our dose divided by clearance times our dosing interval, what do you think are some of the reasons why we might achieve supertherapeutic concentrations, right? Because we know that the higher concentrations go, the more likely we are to have toxicity without necessarily getting a whole lot of extra efficacy out of that. So what do you think are some reasons? Well, if our clearance changes, say our clearance goes down, we have not been monitoring things like renal function, that would lead our CSS to go higher, right? So that could be one reason. Another reason could be our doses increased. We didn't realize it. Maybe the patient got double dosed for some odd reason. Another factor could be in the dosing interval. So say we were giving the medication too frequently, say our dosing interval decreased, that's going to make our denominator go down, which means our CSS is going to go up, right? So what are some ways that we can actually deal with these and can combat or prevent attaining super therapeutic concentrations? On the absorption side, one of the big things we want to look at is going to be compliance. So whether or not the patient's actually sticking with the regimen that we're prescribing. So again, consider the regimen and the patient, whether or not the patient can really keep up with the medication as we've prescribed it. So if we're giving medication, we tell them to take it 6 times a day, well, that's kind of hard for a patient to do. They might forget to take a dose or accidentally take another dose. So usually keeping it simpler is going to be a lot better. So if we can give a drug once a day, it's a lot more manageable by a patient than giving it, say, several times a day. Other things that can affect absorption could be things like abnormal absorption within the bowel. So it can be things like drug-drug or drug-food interactions to where maybe, say, calcium can bind up fluoroquinolones, which are antibiotics, and prevent them from being absorbed. That's obviously going to make absorption of the drug a lot less and lead to subtherapeutic concentrations. This is where patient education can be really, really important. So if things like, if you know there's a drug interaction and patients shouldn't take the drug with grapefruit juice, make sure that they're aware of that prior. Make sure they know the importance of why that is, because it can lead to some pretty significant adverse effects. On the clearance side, some of the pharmacokinetic variables we can run into. Obviously, clearance is greatly reduced when the organs of metabolism and excretion are going to be impaired. So if you have kidney or liver dysfunction, if you have heart dysfunctions leading to less blood flow to things like the liver, can change your clearance pretty drastically. And then always consider dosage adjustments for these patients. It's going to be pretty drug specific, so consult your drug dosing guides and things like that to determine whether you may need to give a drug at the same dose but less frequently, or say maybe you need to give a drug at a lower dose at the same frequency. It may depend on the specific drug and what kind of levels you're shooting for. Going back to toxicities, we can see that there's lots of causes for toxicities. Some of the big ones would be if you're affecting identical receptors that are in different tissues or by a different effector pathway. So looking at things like opioid-induced constipation. Opioid-induced constipation occurs by affecting opioid receptors. Normally in the CNS or in the spinal cord, opioid receptors are good analgesics, but same receptors reside within the GI tract, and by affecting those and agonizing them, it can lead to constipation. You can also have toxicities that occur via different types of receptors. So erythromycin, which is an antibiotic, works as a motilin receptor agonist. It's not something that was originally intended for, but it's kind of a incidental finding that we saw. And so this can lead to diarrhea because it helps to increase GI peristalsis, right? So it could be a toxicity in some cases, or actually it could be used therapeutically in a lot of cases, as I see, at least in pediatrics. A lot of times we're going to be seeing toxicities arise from super therapeutic concentrations of the drugs. This could be intentional in some cases. So like we were talking about with our amphetamines, if you were crushing up an extended release preparation just to get all the dose out at one time and snort it, it could be a potential case of abuse or potentially attempted harm. So definitely in my training in toxicology, saw lots of intentional harm of taking very high doses of drugs into super therapeutic concentrations. There are also some unintentional reasons for this as well. So it could be children getting into medications accidentally, but you can also have impaired clearance over time due to things like age or changes in renal function, which if you're not watching over time can lead to super therapeutic concentrations. So just remember that anything at high enough concentrations can be cause toxicity. So it's important we keep in mind that we are educating patients appropriately and also looking for clearance over time to make sure that we're addressing organ function to make sure things aren't kind of going without being noticed. As far as toxicities go, we'll talk more about tox stuff in Pharm 2 in a couple semesters, but just realize that most substances are not going to have a specific antidote. It's actually pretty rare that we have a specific antidote for medication. And a lot of times tincture of time is really going to be the best cure. So rather than treating a toxicity with another medication, oftentimes by just giving the body time to metabolize the drug is going to be enough of a cure for them and just provide good supportive care in the meantime. But when we get to the tox stuff, we'll talk more about specific toxicities that we can address with antidotes, or in the case of normal adverse effects from different medications, we'll talk about things we can do to mitigate those. So things like opioid-induced constipation and whatnot, we'll talk about those. So again, in conclusion, we discussed the 4 major components of pharmacokinetics. We talked about loading doses, steady state levels, and toxicities. If you have any questions, please feel free to email me. Again, I will try to address any questions that come up throughout the week in the following lecture videos, so at least everyone can benefit from that question. Those will be kept anonymous, of course, so don't feel worried about sounding silly when you ask a question. I guarantee you there are no silly questions when it comes to this stuff. It can be pretty daunting at first, but again, if you have any questions or concerns, please feel free to email me and we can address those. Until then, I will talk to you guys next time.